Bismillah ar-Rahman ar-Rahim. The title of our lecture is Multiple Sclerosis. Multiple sclerosis is a demyelinating disease of the central nervous system. Multiple sclerosis is common in Caucasian, with prevalence of 1 case per 2,000 population. It is an inflammatory disease of the white matter in the CNS. So the important thing is the white matter and not gray matter. It is also an autoimmune disease. It is usually variable disease in terms of disability, rate of progression of the disease, and the prognosis. So there is differences in the progression of the disease and the prognosis. The clinical diagnosis of myasthenia gravis can be difficult, as definite histopathological confirmation by biopsy is not done alive. The clinical features depend on the site of the pathological lesion in the brain. Many plaques are clinically silent. The rate of new lesion is unpredictable and also variable. Subgroups of multiple sclerosis depend on the rate of progression and recovery between attacks. Relapsing and remitting multiple sclerosis is quite distinct from progressive disease. So you know we have different types of clinical presentation. either either relapse remission or progressive. And here we discuss the immunological cause of the myasthenia of multiple sclerosis. The immune pathogenesis is demyelination. So how demyelination of the nerve will occur? By the immunological process. Here the nerve fiber, this is the neuron, this is the axon, and this is the myelin sheath, and this is the oligodendrocytes. And this is the blood vessel, so the macrophage, so the macrophage and the T cells, which is include CD4 positive cells, and secrete interleukin 2, which is need to aggregate more macrophage and migrate from this blood vessel, and then will attack the oligodendrocytes and the myelin sheath of the nerve. And this is lead to acute phase. While the chronic phase, which is the delayed phase, in acute phase there is an inflammation of the myelin sheath. As you know, the end result of any inflammation is fibrosis, which is the late phase of the multiple sclerosis. And here the macrophage begin to phagocytose the myelin sheath. So macrophage containing lipid, which is the myelin breakdown products, which is called foam cell. So what's foam cell? Foam cell is the macrophage engulfing the myelin, and the presence of the plasma cell, which is the source of the autoantibodies. As a rule, in multiple sclerosis is cell-mediated immunity. It's an autoimmune disease which is type 4 hypersensitivity and characterized by cell-mediated immunity, and then autoantibodies will be produced by plasma cells. So this T cells in the acute phase is CD4 T helper. In the late phase CD8, which is a T cytotoxic, and the plasma cell, which is the differentiation and the end result of the B cell. So the nerve fiber only the axon, and all the myelin sheath will be destroyed. This is the only part of the myelin sheath present. And the oligodendrocytes also removed. And this is the only part of the oligodendrocytes. The first nerve will be involved in the multiple sclerosis is the optic nerve. So it's characterized by optic neuritis. Inflammation. What's optic neuritis? Inflammation of the optic nerve. Sorry. Is a similar inflammatory demyelinating disease of one or both optic nerve. So it's either unilateral or bilateral, with recovery in 75 to 90%, which is, as we said before, it is uh, a relapse and remitting. An oligoclonal pattern of the IgG is found in the CSF due to B cell will be differentiated into plasma cell and secreted IgG, which is present in the CSF from most patients with optic neuritis. Why due to IgG? Because IgM has short half-life. The IgG, which is present for long period of time, half-life is more. And IgG indicate the chronic stage. So when IgG is present in CSF of most patients with optic neuritis, so this is the latest stage of multiple sclerosis. And nuclear magnetic resonance MRI shows silent lesion elsewhere in the brain. It can be due to many causes, but approximately 50 to 80% of patients will develop multiple sclerosis within 15 years. And in the MRI, we found the plaques, which is the fibrosis, which is the scar tissue as here in this MRI figure. MRI scan of the patient's form, and this is the plaques. We must differentiate it from the senile plaque, which is due to senility. Here, multiple sclerosis in the old patient. So we must ask out the age of the patient when we have this MRI. Clinical diagnosis of multiple sclerosis depends on evidence of at least two attacks separated in time and site of lesion, with exclusion of all other causes that we other causes, other neurological causes. Confirmatory tests are required. Poor nerve conduction can be demonstrated by prolonged response on evoked potential testing. We send for the diagnosis, send the patient with optic neuritis for the visual evoked potential. And for an MRI, which is more common used of the brain, showed lesion in 90% of affected individuals with multiple sclerosis. Like all imaging is non-specific and can be unreliable, especially in the elderly, as we said, the senility, due to senility. The pathological lesion in multiple sclerosis seen at post-mortem brain biopsy is a plaque. This is the plaque. This is an area of the white matter in which myelin and oligodendrocytes are absent. Myelin is a protein phospholipid material that surrounds the axon in multi-layered dense spiral. Myelin sheath in the CNS are formed by compacted membrane of oligodendrocyte extension. And the integrity of the myelin sheath depends on the maintenance of normal oligodendrocyte function. Axons without myelin sheath are poor conduction or poor conductors of nerve impulses, resulting in a neurological defect. So why the neurological defect occurred is due to absence of the myelin sheath, which is lead to poor conduction. In the early stage of a plaque, there is tissue edema, apoptotic oligodendrocytes. So, and infiltrating cells, lymphocyte, macrophage, are seen around the venule in the area, as we explained before in the figure. B cells are also involved in the local production of immunoglobulin, while others, including T cells, macrophage, are part of the acute inflammatory process. Routine examination of the CSF is not enough. Spinal cord tap. It is essential to look at the nature of the immunoglobulin. Immunoglobulin present in the CSF may have been synthesized in the CNS or possibly transferred from the serum. So the sources of these antibodies either from the serum or synthesized in the CNS. The concentration of the CSF IgG is best expressed in relation to another serum protein, not synthesized in the brain, as this level will indicate the integrity of the blood CSF barrier. Most formulas are based on the ratio of the IgG over albumin. This is the important ratio, measured by the same technique. Intracerebral synthesis of the IgG will produce a rise in the IgG albumin ratio. However, if the rise CSF IgG concentration is due to leaking a blood-brain barrier, then the albumin content will be similarly elevated and the resulting IgG albumin ratio will remain constant. So we must depend on the IgG albumin ratio. The IgG synthesized the IgG synthesized in the brain is restricted in nature, has a narrow range of isoelectrical protein and appears as a typical oligoclonal bond. so we do CSF electrophoresis to find the oligoclonal bond. CSF from patients with cerebral infections such as neurosyphilis or subacute sclerosing panencephalitis, which is the differential diagnosis of the multiple sclerosis, show similarly pattern, although such condition rarely cause diagnostic difficulty. The cause of multiple sclerosis is unknown. As a rule, with all autoimmune disease, the precise cause is unknown. But this multiple sclerosis is due to interaction between two factors, environmental and genetic factors. Several epidemiological observations link multiple sclerosis to exogenous environmental agents, but vitamin D deficiency, but extensive efforts to isolate specific agents in multiple sclerosis have failed. There appear to be no single trigger. It is multifactorial factors. We found that the experimental autoimmune encephalitis induced by immunizing susceptible mice with myelin proteins can be transferred to non-immunized animals. This is the experimental to show us how multiple sclerosis induced. The precise immune pathogenesis of demyelination is not clear. Many inflammatory cells are present in the local lesions known as plaque. Whether cell injuries, the oligodendrocytes directly or whether the damaging results from viral. This is the environmental factor that cause to multiple sclerosis, viral, viral infection, toxin. New data suggests that apoptosis of the oligodendrocytes may precede inflammation and demyelination. CD4, CD8 T cells will be involved. Myelin basic protein are present in blood and brains of the patients with multiple sclerosis, which is the autoantigen. The body will recognize that the myelin sheath is an autoantigen, whereas previously CD4 cells are thought to be most important, which is found in the acute stage. Newer data favor CD8 T cells as the cause of the oligodendrocyte death, which is in the late phase, and CD4 responsible for the inflammation. However, the precise nature of the sensitizing process and the cytokine involved, like interleukin 2, remain mystery. Activated macrophage also will be involved in this story, and approximately find on their macrophage present proximate in close association with myelin striped axons and probably involved too. Autoreactive T cells are found in healthy people but are activated only in patients with multiple sclerosis. Regarding the human CD4 regulatory T cells, which is characterized by the two CD markers, CD4, CD25, can prevent activation and function of other T cells, which is new cell, which is Treg. It's abbreviated by Treg, where formation. Some numbers of Treg suppressor cells were found in healthy individuals and multiple sclerosis patients. Those Treg cells from patients with multiple sclerosis were less able to inhibit specific activation. And this suggests that impairment of the Treg cells may contribute in the breakdown immune tolerance in patients with multiple sclerosis. So why autoimmunity occurs, which is due to failure of the T regulatory cells, which is the peripheral tolerance. The T regulatory cells is responsible for the peripheral tolerance. As you know, we have central tolerance and peripheral tolerance. Central tolerance occur in the thymus, while peripheral tolerance occur in the periphery. The another factor contribute in the multiple sclerosis is genetic factor, which is involvement of the HLA, which is HLA-DR2, DR1, DQ1 antigens in the Northern European and Northern American. But the susceptibility of the individual will be multifactorial, including environmental agents. So they found that people live away from the equator in North America and Europe are more susceptible to multiple sclerosis due to less exposure to sun, due to less production of vitamin D. Treatment. There is no specific treatment because it is an autoimmune disease. It depends on the generalized immune suppression, and this is achieved by high dose of corticosteroids. And this is an acute attack to suppress the inflammatory response and elimination of inflammation component does not disease progression. Then the efficacy of interferon, this is with the high dose of corticosteroid use the chemotherapy, which is generalized immune suppression. while here we will concentrate on the localized immune suppression by using immune therapy suppress only the immune system, and this achieved by using gamma interferon. And its use is controversial. Its use of high dose of human intravenous immunoglobulin therapy, since both are expensive and their use is limited. Coprimer 1 shows some response in the immunotherapy with humanized antibodies proved successful, and another monoclonal antibody. This is the MAP. When there is a presence of MAP, indicate MAP monoclonal antibody, not Lizumab. A monoclonal antibodies against integrin Vela 4 has been shown to be clinically effective. It's thought to act by preventing the entry of the damaging cells into the white matter, but serious side effect presents humanized anti-CD25 antibody, which is inhibit interleukin 2, as we said, interleukin 2 contribute in the immune pathogenesis, so we use monoclonal antibody against the interleukin 2. Signaling and looks promising in therapy for those patients with incomplete response to interferon beta therapy. Nowadays, in the medical city hospital, they use monoclonal antibodies in the multiple sclerosis patients. And patients come routinely to receive or to get his treatment. Open label study, there was 70% decrease in contrast enhancing lesion compared with treatment. Interferon beta in trials of immune stimulation have been working, and interferon gamma made the disease worse. This is experimental studies. The prognosis of multiple sclerosis depends on the subtype of the disease. It is overall 20% have died 20 years after diagnosis, and it is disabling disease. This is the epidemiology of this disease. The present. Thank you.